Transcranial Ultrasound in Pediatric Sickle Cell Disease. I'm happy to announce that we had over 300 participants registering for this webinar from over 20 countries across the globe. The biggest contingent coming from Uganda, and the second from Ghana, West Africa.
Thank you, and I hope all the success with you guys, and thank you for giving me this platform. So today I'll be going through transcranial Doppler, more specifically for children with sickle cell disease. I currently run multiple clinics all across London for patients with sickle cell disease that obviously are migrants, mostly from Africa and even Asia and even South America as well. So it's something that I hold close to my heart, and very interesting area that I would always like to provide more insight for our professionals in ultrasound. So I think to begin with, it's important to know and understand our viewers, and Edwin will help us out here by providing a poll to see how many of our viewers already or have performed TCD scans before. So when you're ready, Edwin?
I've just projected a poll which should pop up on your screens. If you don't see that on your screens, check in your chat. And it's a multiple choice question. Just click the correct answer and submit. I will give the next maybe 3 minutes and I'll tell you the results of the poll.
Yeah, I mean, this is just to kind of understand our viewers as well, and many people also joining the webinar, so it gives us a little bit more time for them to not miss out any information. But in the same time, if you already do TCD scans on your practice, then a lot of this information you will already know, but many others will not have that kind of expertise. So it's always good as a refresher, I guess. So if you already know some of the information, please, kind of be patient with this presentation, because many others will not know. So once we get the viewer numbers and the understanding of how many people do perform the scans, we'll just move across.
Let's give it 1 more minute and I'll tell you the results. They look promising, by the way.
Oh, yeah?
Mm-hmm.
I think this is the great thing with Ultrasound Africa. They cover such a broad spectrum of different professions and different kind of subspecialties, and it's the sharing of knowledge is always key.
Thank you, Ibrahim. Thank you. So should I tell you how many people do actually perform transcranial ultrasound, Doppler ultrasound?
Sure.
So 32% of the respondents say they've done this scan before, and about 68% say they've not done it before.
Okay.
So you have about 1/3 who've done this scan before.
Sure. So there is quite a few of you of the viewers and colleagues who have performed it before. So we'll just crack on with the content of this webinar. So essentially, we will be looking into sickle cell disease and its manifestation, but it's going to be more of an overview rather than an in-depth dive into the disease itself. We are practitioners of ultrasound, so we are more on the diagnostic aspect rather than the treatment aspect. We look for the diagnosing, which is obviously in the initial steps. So it's something that I'll be focusing more into, and especially obviously transcranial Dopplers. So moving on essentially we look at the stroke and SCD, basic transcranial Doppler principles. I won't go into too much physics, but it's important to understand some basics with regards to the physics involved. Stroke prevention trials. So these trials provided the foundation for all the screening that we provide today. These trials found something so substantially important for children with sickle cell that it paved the way for many treatment options for TCD for children with sickle cell, and prevented so many stroke incidences. So these trials, I recommend all our colleagues and viewers to look into these stroke prevention trials, which abbreviated as STOP trials. And then the TCD modalities, which obviously covers non-imaging TCD and imaging TCD. And then following the TCD diagnostic aspect, what happens next? Which is communicated as a decision tree. So depending on the results, there will be a aspect where you will go and follow a particular pathway following the examination. So we'll go into that, and then we'll get into some case examples of some of my scans and some of scans that have been performed, and we'll just keep it as interactive as we can and get you guys involved. It's important to have some sort of interaction with our colleagues and viewers. So beginning with, we have to understand what sickle cell disease is, and many of you will know this already, and many of you will know somebody who has sickle cell or has known somebody with sickle cell, and it's something that is highly relevant to all our colleagues and viewers in Africa and in other areas of the world as well. So sickle cell disease is a group of blood disorders typically inherited. The most common type is known as sickle cell anemia. It results in an abnormality in the oxygen-carrying protein hemoglobin, brown blood cells. This leads to a rigid sickle-like shape under certain circumstances. Problems in sickle cell disease typically begin around 5 to 6 months of age. A number of health problems may develop, such as attacks of pain, which is typically known as a crisis, anemia, swelling in hands, feet, bacterial infection, and stroke, which is the number one thing we are trying to prevent here with our screening of our patients. So long-term pain may develop as sickle patients get older, and the average life expectancy. I say this with hesitancy because it's, this is a developing area, and we are getting more medicine and development in this field of medicine. They're so-called between 40 and 60 years old, but I wouldn't put too much emphasis on that number. So in SCD, it's the polymerization causes the red blood cells to sickle, as I mentioned before, and it's in the a genetic mutation in the beta globin gene. So the polymerization of the HBS is a consequence of deoxygenation, which causes the red blood cells to sickle. And I'll get into that in more detail. I think I've shared this reference for our viewers to do a little bit more research in, if they don't really know to. But the three main pathologies that are associated with SCD is vascular occlusion, right here, hemolysis, and anemia. So the area where we screen for, we always screen for vascular occlusion or potential vascular occlusion disease. So essentially here, if you just have a look at the healthy red blood cells, as you can see, it's a spherical shape, and healthy red blood cells with hemoglobin carried oxygen maintain their shape and how the hemoglobin is distributed around the blood cell itself. Whereas in sickle cell, hemoglobin clumps together and it tends to distribute on one side of the cell, and that causes the sickling area here. And that causes hemolysis, which is the destruction of the cell, and in turn, anemia. Stroke and SCD, it's obviously a devastating complication of SCD, and it affects around 5 to 11% of patients under 20, and most frequently 11% in children with sickle cell anemia. Infarctive stroke is most common in children under 20 as well. So the role of sickle red blood cells in vascular, as you can see in the diagram here, the sickle red blood cells interact with and activate the vascular endothelium, leukocytes and platelets, and bind to coagulation factors and plasmin protein forming aggregates. So this combination of different interactions within a blood vessel cause progressive occlusive disease within the blood vessels itself and possible blood status. So you can see it as the coupling region going on here. And, you know, this could be the middle cerebral artery, anterior cerebral artery, and then that can cause an infarctive event. So just to kind of give you an overview, stroke incidence is highest between age 1 to 9 years old. And I've had cases in my clinic where, unfortunately, before we can do any screening, we've had patients who, you know, around 3 and 4 years old of age and have suffered from stroke, which is quite devastating to see a child have this kind of this consequence. You know, it's very upsetting, and it makes you obviously want to help as much as you can. And the average age of the first stroke is usually 6 years old. Reoccurrence is 67% of children 1 to 2 years after initial stroke. This was before any screening as well. So the recurrence rate is quite high if there was no blood transfusion, any form of treatment plan provided. So the incidence of stroke decreases in ages between 20 and 29. That's why we don't do any transcranial Doppler screening at around that age. But then it increases between 35 and 45 as well. So this is obviously it's not something that it's not within my remit, but I just thought it's interesting to just show an MRI image showing a patient who has the sickle cell trait, which is labeled here as a healthy control number, healthy control patient, and somebody who has sickle cell anemia. So as you can see here, there's an infarctive event as you're going on over here compared with the control. But when I look at this image, what I am mostly interested in is the angiogram. As you can see here, you can see a substantial amount of flow volume here in near the middle cerebral artery region right here when compared to a normal control. So obviously, if there isn't any infarctive event, there is much more volume, and that could be due to a deficit region. And in terms of the vessels itself, it doesn't have to be occluded for it to be affected. And in that respect, there's higher volumes in the angiogram compared to the controlled patient here. So a little bit of epidemiology going on here. So about 5% of the world's population carries genes responsible for hemoglobinopathies. Each year, around 300,000 infants are born with major hemoglobin disorders, including more than 200,000 cases of sickle cell anemia in Africa. Globally, there are more carriers, healthy people who have inherited one mutant gene from one parent of thalassemia, than of sickle cell anemia. But in the high frequency of sickle cell gene in certain areas lead to a higher rate of affected newborns. So it's just basic maths. So if more carriers are within a population, within a city or an area, then the interactions between the carriers will in turn cause newborns with sickle cell disease. So sickle cell anemia is particularly common among people with ancestors from sub-Saharan Africa, India, Saudi Arabia, Mediterranean countries. And the migration raises the frequency of the gene in the American continent as well. So in North America in particular, and in some cases South America as well, sickle cell it's highly prevalent there, and it's something that is commonly researched and commonly screened as well in North America, and they do a lot of good work over there. So we always look to our American colleagues for more research and developments. In some areas of sub-Saharan Africa, up to 2% of all children are born with the condition. In broad terms, the prevalence of sickle cell trait healthy carriers, inherited gene, mutant gene, from one parent range between 10 to 40% across equatorial Africa and decreases between 1 to 2% to the north of Africa. So you can see that the prevalence is quite high when you are a carrier. So it's, again, as a consequence of multiple carriers, there will be newly affected newborns. To bring it back home a bit, here it just shows the newborn with sickle cell anemia according to data in 2015. So in Nigeria records the highest disease incidence in the world with over 91,000 children with sickle cell disease. The rate accounts for almost 2% of all newborns annually. Following Nigeria, you got the Democratic Republic of Congo coming in second with 39,743 sickle cell births per year. And then Tanzania with the 11,877. And in Uganda, which a lot of our colleagues who are participating here are from, they contribute 10,877 births of sickle cell a year. And then Angola, Cameroon, Zambia, and then followed by Ghana, Guinea, and Niger. So you can see how prevalent it is in Africa, and it's something we should always be aware of, and hopefully in future there will be much more treatment options. So this is just an overview of what we were talking about. We've already understood what sickling of the red blood cells are and what the gene mutation that causes the sickling itself. And as a consequence of sickling in the blood, you get acute and chronic complications. So acute complications such as obviously a stroke, sepsis, splenic issues as well. Whereas chronic, it's more of poor growth, renal disease, retinopathy, learning and cognitive difficulties. So it's something that is wholly important to these patients to actually get treated and diagnose and screen. It can have consequences that are very long-term and very areas of clinical significance as well. So in terms of management, a lot of our patients, we teach a lot of the families the splenic palpitation to understand if there is any rapid increase in splenic enlargement, for example, in fever as well. All of our patients are on folic acid and penicillin as a form of a prophylactic. Hydroxyurea is something we've been introducing to all our patients as well, which obviously decreases white blood cells and increases total fetal HB. Red blood cell transfusion is a common following if there was any higher levels in screening. So the red blood cell transfusion is a common area of practice. And the only cure, so-called cure for SCD is a stem cell transplant. But we maintain our patients and commonly screen them using our transcranial Doppler, which we get on here. So basic transcranial Doppler principles. I'll go through this, not in that much depth, but I believe many of our colleagues have performed this already, but it's good to just have an overview as well. So TCD ultrasonography is based on the principles of the Doppler effect. According to this principle, ultrasound waves emitted from the Doppler probe are emitted through the skull and reflected by moving red blood cells within the intracerebral vessels. As you can see, the probe, the ultrasound is given off and returned to the probe here. So the difference in the frequency between the emitted and reflected waves, referred to as the Doppler shift frequency, is directly proportional to the speed of moving red blood cells and the blood flow velocity. So the specific parameter obtained from this is spectral analysis, including peak systolic velocity, end diastolic velocity, systolic upstroke, accelerate time, positivity index. But the area that we are commonly looking for is time average mean maximum velocity. And I'll go into that later on, but just bear that in mind, the time average mean maximum velocity. And this parameter was used in the trials, which is the foundation for all our work in screening. Okay, so this is just more of the Doppler principle. So as you can see here, the frequency transmitted and the frequency received. We got our equation here, so Doppler shift principle and the acquisition of ultrasound data. The transducer emits the ultrasound pulse at a transmitted frequency and is reflected from the moving red blood cells within a vessel and received frequency. The difference between the transmitted frequency and the received frequency is the Doppler frequency shift, the movement. The angle between the direction of blood flow and the direction of the ultrasound beam is that Doppler angle, which is equated within the equation itself. So the Doppler frequency shift equation enables one to calculate the velocity of moving blood. The amount of blood shift depends on the frequency of the transducer, which in our case, it has to be a low frequency transducer. Frequency of the reflected echo, velocity of the moving reflector, angle between the transmitted beam and the flow direction, the Doppler angle, which is commonly used in arterial duplex ultrasound, and velocity of the sound in the reflecting medium. So the stroke prevention trials between 1997 and 2002 were, like I said, the foundation for all our work when performing the screening. So the stroke prevention trial is a sickle cell anemia stop trial, was the first prevention trial in HBSS and the first randomized controlled use of transfusion in HBSS in sickle cell. This was a multi-centered trial, was designed to test whether reducing hemoglobin to 30% or less with periodic blood transfusion will reduce the first-time stroke by at least 70% compared to a standard care. So they just wanted to reduce the hemoglobin and obviously replace it via blood transfusion, and to see if that will decrease the occurrence of stroke in many of the patients. So the trial demonstrated a large benefit of transfusion and was halted early. So I can't emphasize this enough. This trial was halted early because of the results were so compelling that they halted it early. After termination of the trial, patients participated in a post-trial follow-up study. More patients in the transfusion group, about 70%, elected transfusion for primary stroke prevention, compared to those with standard care, 45%. 6 patients persisted abnormal TCD resulted in developing stroke. So those who have not post-trial who have not continued the transfusion treatment and prevention, they went on to develop persistent abnormal TCDs and in turn stroke. Transfusion resulted in iron overload and allonormalization, but no infection. The study provided new information on acceptance rate and long-term effect of transfusion, persistent TCD elevation signal, ongoing stroke risk as well. So this was the actual trial, and I recommend all our viewers and colleagues to log on and research this trial as well, these trials as well. And it's, like I said, it had fundamental findings for all our work, and screening was based on their findings. So the key point to take here is 92%, which is it's overwhelming actually, 92% reduction in stroke risk with patients going through chronic transfusion versus just standard care. So with just standard care, you just get in folic acid and penicillin. Whereas if you had high TCD with transcranial Doppler, and then you've had transfusion, then you had a 92% chance or a reduced chance of stroke. So a 92% reduction of stroke risk at that respect. So the results demonstrate a large benefit as transfusion and TCD being key here. Like I said, evidence was so compelling, the trial was halted before completion, and then there was a clinical alert sent out worldwide to guide our other practitioners around the world of these results, and recommended screening and blood transfusion as a pairing for long-term treatment. So there was an indefinite transfusion for those with abnormal TCD, and the value here, like I said before, is time average maximum mean velocity. From the results, the TCD results were classified according to, like I said, the time average maximum velocity, which directly related to a stroke risk. So if a patient came in and a pediatric patient, and we looked into certain intracranial vessels and the velocities were below 170 centimeters per second TAMMV, then their stroke risk was around below 2% if it's below that point, according to the STOP trials. Whereas if the velocities were between 170 and 199 centimeters per second in TAMMV, then the risk increased to at least 7%. And then if it was above 200 centimeters per second, then there was a 10% risk of stroke. So that's a 1/10 risk, which is quite substantial. Low velocities may indicate vessel occlusion. So in those cases, an MRI or CTA was commonly used as a follow-up for the patient. Inadequate scans may be due to poor scanning window, uncooperative children, and we start our scans on these patients from 2 years old, so it will be challenging. A lot of these child patients, it's something that is new to them. It's new environments. So in most cases, when I scan 2-year-olds, I try my best to be as patient as I can, but it's very, very difficult. But you have to try nonetheless. Inadequate scans have an aggregate stroke risk of 1 to 3%, but obviously it's not definite here. So you got this illustration here. As you can see, the internal carotid goes up, and then the middle cerebral artery, as you can see here. We have the ultrasound probe usually via the transtemporal window. we place in the region here, and we look into the middle cerebral artery as a point of reference. So as you can see here, the middle cerebral artery, you interrogate the middle cerebral artery until you by obviously increase and decrease in depth, and then you understand where you are located within the intracranial vessels, and then from there you could start to integrate interrogate other vessels such as the anterior cerebral artery, posterior cerebral artery, the terminal point of the internal carotid artery. As you can see here, the anterior cerebral artery. You can place the probe, manipulate the probe to acquire which vessel and area that you would like to interrogate. So for example, if you tilt your probe anteriorly, you would more likely at a certain depth look into the anterior cerebral artery, whereas if you tilt your probe inferiorly, you will get the terminal point of the internal carotid artery. So these are the main vessels here, as I've shown here: the middle cerebral artery, terminal internal carotid artery, anterior cerebral artery, and posterior cerebral artery. So with regards to the examination itself, TCD uses around a 2 megahertz ultrasound and sweep speed of around 3 to 5 seconds. The area receiving the ultrasound is referred to as the acoustic window. And in the head, this could be a number of areas. As you can see here, the most common area is the transtemporal region right here. However, I don't commonly practice this, but you can do the transorbital, you can do the suboccipital, you can do the submandibular window as well. Like I said, the transtemporal window allows inspection of the terminal internal carotid, middle cerebral artery, anterior cerebral artery, and posterior cerebral artery. There are communicating arteries, obviously, as well, but that's something that wasn't covered in the STOP trial, and we don't interrogate it very much here. So, types of TCD devices. I'm sure many of our colleagues have normal ultrasound machines such as an IU-22, and not many would have a dedicated TCD non-imaging machine, but for the purposes of learning here, we'll cover both, so non-imaging TCD as well as imaging TCD. So non-imaging TCD is you can see the device here and the probe. We're looking for the vessels I mentioned before, but you're looking and identifying these vessels blindly based on the audible Doppler shift and the spectral display. So you'll see the spectral display, and each vessel has its own distinct audible noise that you can, with time and experience, will understand and differentiate between them. Vessel differentiation and identification is based on standard criteria, which includes the cranial window used. So obviously the transtemporal, which is commonly used, orientation of the probe. As I said before, if you orientate it anteriorly, posteriorly, inferiorly, depth of sample volume, direction of the blood flow, relationship with relation to the terminal internal carotid artery, and a response to various maneuvers such as the common carotid artery compression and eye opening and closing. Signal Doppler box setting can be as you can see here, the Doppler box can be an integrated system which has the Doppler box, which is, and the screen and the probe, it's all an integrated system. Or you can actually just get a Doppler box and connect it to a laptop, and obviously, yeah, you'd have to have a software for you to visualize the vessels, but it can be a inexpensive mode of screening as well, rather than buying a whole ultrasound machine for this specific screening. And I think it's good for transport as well. You can easily place a Doppler box. I mean, I've provided outreach programs outside of London, and I've gone across England as well. And I've just had my Doppler box, which is, you know, it's a very small, as the name suggests, a Doppler box. And I went with a laptop and a Doppler box, and I went across to different hospitals in the UK, and I was able to provide good, accurate, and replicatable results across different centers, rather than, you know, transporting a whole ultrasound machine across different trusts would not be very ideal. But as I said, it's only dedicated for that purpose, so that in itself it can be a disadvantage. So you can see here the spectral image here. So ideally, the patient would be supine, awake, and quiet, and not sedated. A 2 megahertz ultrasound probe aligned with the specific cerebral artery blindly, which will always be the middle cerebral artery to begin with. And then, as you can see here, the parameters I would use, so this is an image that I've taken, is the depth. So I would start usually with a depth of 40 millimeters, and then as I interrogate the vessel, I increase the depth by 2 millimeters to understand the location in which I'm interrogating, the gain and the sample volume, and the power with regards to the ultrasound beam. You can't always have a thin temporal bone, so it's ideal that you interrogate the temporal region first before going anywhere else. So this is some waveforms I acquired from the patient. As you can see here, the middle cerebral artery is this kind of waveform is commonly obtained from the middle cerebral artery. As you can see here, at a certain depth, as you can see. As you move down the middle cerebral artery, you will get to a point where the flow is also going towards the probe, but also going away from the probe to the anterior cerebral artery. So you get a bifurcating, a waveform that is positive and negative here. So as you can see, the flow is going towards the probe and away from the probe, where there is a bifurcation area here. And then once you move on to the anterior cerebral artery, or if you want to look into the posterior cerebral artery, you get different waveforms here. And as I was saying, the anterior cerebral artery, you will see this this kind of waveforms. So I hope you appreciate the different waveforms and the depths in which these waveforms are obtained. And essentially, you would have to go through the vessel and interrogate it in 2 millimeter intervals. And from there, you will understand which area of the intracranial vessel you're interrogating. So for example, you would start at 40 millimeters, increase into 2, and then once you get to, as it says here, 58 millimeter depth, you will see you're picking up signal from the anterior cerebral artery whilst you're still in the middle cerebral artery. So I'm guessing this is the region there. And then once you tilt the angle of the beam towards the anterior cerebral artery, your middle cerebral artery fades away because you're not in the vessel anymore, and you're mostly interrogating the anterior cerebral artery. So you will get an image like this. Again, these are images from my clinic. You can definitely see that the middle cerebral artery has its distinct waveform. And once you get down to the bifurcation area, you can see that there is a waveform above and beyond and below. So you're getting a signal from 2 vessels here, away from the probe and towards the probe. And then again, you see interrogate the anterior cerebral artery, and then you got here the posterior cerebral artery as well. I can't emphasize enough, but the distinct audible noise will always help when in trying to differentiate between each vessel. It's an area where, for example, if you're not sure if you're getting the internal carotid or the middle cerebral artery, with the internal carotid, it's more of a you see that you hear a more of a thumping, distinctive noise. So, and that will tell you if you are close or within the vessel itself. Okay, so I'm going to get Edwin to kind of come in here for this slide. It'll be interesting to see if everybody is following, to see which intracranial vessel does this waveform belong to. So Edwin will provide a poll, and it will be interesting to know what you guys think. So Edwin?
Yes, Ibrahim. I've sent out the poll. I'd want to see if my colleagues are as attentive as I am in your presentation, because I've been paying good attention. So let's give it about 3 to 5 minutes to get the answers in.
Yeah.
If you can't see the poll, it's a pop-up message. If you can't see it, check your chat. It should be in there. Don't type the answer in the chat, because then I can't get the percentages. But the question will be in the chat, and then you can click it from there.
For those who wanted to kind of compare, so these are the images, and this is the image here.
Good. Responses are coming in.
Yeah.
Let's give it another minute, and I'll tell you the result. I'm seeing some responses changing.
Oh yeah.
I think people are changing their minds too.
I think me going back might.
I think so. I think so.
It would be interesting to know what they changed from and to.
I wish I would tell you that, but I can see some responses changing as well.
Let's see who has attention to detail.
That's the key. Attention to detail. It's the posterior cerebral artery, and none of them think it's the terminal internal carotid.
Can you say that again? So you said how much for the MCA?
70%.
70%.
Yes.
MCA, and then?
And then only 8% think it's the ACA.
Okay.
And 22% think it's the PCA.
Okay.
And now 3% now think it's the terminal internal carotid.
Oh, so they changed now, right?
Now they switched, yes. let's
learn. Fair enough. So 8% thought it was ACA, 70% thought was the MCA, and 22% thought was the PCA.
Yeah.
Early dying. So just having a look at the images here. You look at the MCA itself, and then just look at this MCA. There's key differences, isn't there? I think let's go back to the fundamentals. Since when do you see a upstroke of velocity in spectral waveform go up and down? I think I'm being unfair here, to be honest. It's quite unfair. It is quite unfair. And I think Edwin himself fell for it as well. This is just kind of, lighthearted to see if everybody's paying attention. But this is, in fact, the ACA turned out upside down. So it's just to see people have a little bit of attention to detail. And essentially, you can see here, this is the image here of the ACA. And it's the ACA upside down. You can see the this parameter shows within when you are inside the vessel, and gives you an understanding within the vessel itself. So yeah, so this is just light-hearted interactions here. You know, so well done to the 8%. I bet you didn't know
I was
why.
part of the 8. I was part of the 8%, by the
Are
way.
you sure about that?
Yeah, I was. I think importantly to note is look at the color scale as well.
Exactly.
For my colleagues, the color scale was a giveaway to tell us that this was an inverted waveform,
Yes.
having the red and blue alternate, and that was the catch. But yes, it was a tricky one.
As you can see, I just you know, it was just a light-hearted, just to see who's paying attention to detail, like we said, Edwin. Attention to detail.
Attention to
As you can
detail.
see here, that's it.
Yeah.
Perfect. We're moving on now. We'll look into imaging. So we covered non-imaging. I like to do a lot of imaging, TCD. I like to know what I'm looking at, and but does that mean it's more accurate? Not necessarily. With imaging, you obviously can see the vessel, but are you, unless you have very good practice, do you measure different velocities at different intervals as you do the non-imaging? Not necessarily, but it's more difficult to do that. So with imaging, obviously advances in ultrasound equipment and the utilization of grayscale, color Doppler flow, and spectral Doppler imaging, direct visualization of the vessel and more accurate flow velocities can be or is possible. I don't quite agree when it's so heavily operator dependent, but it can be accurate as well, because you actually can see the vessel. So imaging of the circle of Willis is performed usually in a transtemporal approach, utilizing a 1 to 5 megahertz sector array transducer or phase array transducer, and with most of the imaging being performed at low frequency at around 1 to 2 megahertz to allow penetration of the temporal bone. The transducer is placed on the temporal bone, either above the zygomatic arch and anterior to the external auditory canal, or slightly more salivate and posterior over the earlobe. Imaging is performed from the left and the right temporal bones with color Doppler flow imaging utilization to visualize the vessels. So a lot of our colleagues will have this, what I would like to call a bad boy, the IU-22. It's a very robust ultrasound machine, and all you need to do is get a phase array transducer that has capability of low frequencies between 1 to 2 megahertz. So with imaging TCD, like non-imaging, you will have different spectral Doppler waveforms, and but you actually see the vessel itself. So you would start with the MCA. I would look at the MCA, and I'll take 3 to 4 different samples from the vessel. So I would look at distal, middle, and more proximal here. And at that point, I would tilt my probe inferiorly to get the terminal ICA, anteriorly to get the anterior cerebral artery. In fact, you can take samples from both sides, so you don't have to interrogate both only one side. You can actually see both sides. You can get the MCA, and you will get the left MCA, for example, and the right MCA as well. It's crucial and important that patients undergoing a TCD exam are not asleep, for example, or crying. When you go to sleep, you relax and your respiration decreases. Your body responds by increasing the velocity of the blood going to your brain. to ensure an adequate supply of oxygen. This would give you a false positive result on the TCD examination. On the other hand, when a patient is crying, their respiration increases, your body responds to this by decreasing the velocity of blood going to the brain, preventing too much oxygen from being delivered. In this situation, it can give you a false negative result on a TCD exam. So as you can see here, again, this is just different important notes to consider, and essentially to always have in the back of your mind, because when you have children as young as age of 2 and they come into your clinic and they're crying and very uncomfortable, it's not worth continuing with the examination. So as a rule of thumb for me, I try my best to keep them proactive, keep them engaged. But when they go in a tantrum and they cry and cause a lot of distress, at that point the results will become skewed, and it won't provide any diagnostic value to continue with that scan. So, and I mean, in the same respect, if you're scanning a patient and they go to sleep, again, that can cause a false result. And at that point, you always have to try to make sure that they're attentive and awake throughout the whole scan. This is a pro forma that I use with some of my patients. So, as you can see here, you can you take down the velocities, the time average mean velocities for the MCA, ACA, terminal ICA, and PCA. I would always put more emphasis on the MCA and ACA here, because they are the main parameters that were used in the STOPS trial. The PCA, not so much, and the Vascular is not, it's not as important for, I mean, in the purposes of this examination, the MCA and ACA are paramount to understanding what threshold they would go under here. So normal, conditional, high conditional, abnormal. So once you have the results from both sides, you can understand and place the history on the scan quality, if it's good, if the MCA was traceable, and then if you had some difficulties, you can also take, there's a lot of bone compliance, skull bone attenuation, absent signal, you can take it here. I think it's also important to understand if the patient is already on blood transfusion or taking hydroxyurea. So if they're on blood transfusion, then ideally you would not like to scan them immediately after a course of blood transfusion. So I wouldn't scan a patient 1 week after, or less than 1 week after a blood transfusion, because at that point it defeats the purpose. It really defeats the purpose. You would like to understand the state of sickling in that blood. So if you had a blood transfusion already, then you're not getting a reflective kind of sample that would show you the probabilities and risk of stroke. So what I would do is I would schedule my patients who are ongoing active blood transfusion to have these TCD scans prior, at least 1 day or a couple of days prior to their next course of blood transfusion. So I would, if the patient was on transfusion, then I would also write the date of the last transfusion and understand when they've had it, and then make a decision on when, if the TCD scan is clinically, diagnostically appropriate or not. Again, so we have here on the bottom the classification. If, for example, the patient has 170 centimeters per second on the MCA, and the right MCA here, then you would classify it on the bottom and follow it up with next course of action. So if you have a patient with, say conditional results, then you can see it would account for a 3 months visit following the examination. Write it on the comments. I will go into the next course of action in the tree, as I mentioned earlier. That will give you more of an insight and of the planning involved for the patient. There's a tree. So you get your child aged between 2 and 16 usually. If it's a normal scan, then you repeat the scan annually on a yearly basis. And again, all of these decisions and parameters to follow for the diagnostic purposes of TCD is followed and provided by the STOPS trials. Again, I can't emphasize how important they were in shaping all our clinical and diagnostic treatment for patients with sickle cell disease. So normal scan, anything below 170, repeat within 1 year. Conditional scan, it's repeat between 6 weeks to 3 months, depending on if it's high or if it's conditional or high conditional. So if I go back here, you got two different parameters. If it's high conditional, then I would see them between 6 to 8 weeks. If it's just below 185 and conditional, then it's usually 3 months. So for example, if it's 177, I would see them in 3 months. Whereas if it's 190, so essentially that's below 200, but above the 185 mark, then I would see them between 6 to 8 weeks time, as you can see here. And then when it's abnormal, anything above 200 centimeters per second time average mean, we would do a repeat scan within 1 week. Because once it's over 200%, the chances of stroke, as I mentioned before, was 10%. So that's quite a substantial percentage. So we would also try to mitigate all risk, and that consequence or area of scan results, then we would do it within 1 week and then discuss stroke risk and transfusion considerations. So the hematologist and pediatrician would get involved here and discuss blood transfusion and see if the abnormal scan is reproducible. So we would scan in 1 week and then that's something we would have to consider, because 10% chance of stroke is still a substantial percentage. Okay, so I'm going to get Edwin to come in again.
Yes, Ibrahim.
Hello. So again, all right, we are not playing around this time. No mischief. These are actual cases. Nothing's going to be flipped around here or anything like that. These are case examinations from a patient who's a 5-year-old female with established diagnosis of sickle cell anemia, presented for annual screening. What I'd like Edwin to do is, as you can see here, the right MCA, the left MCA, again, there's a prox and distal here as well, to provide a poll to see if, according to the Stoke trials, what do you think it is? What do you think these values are? Is it normal, conditional, abnormal, low velocity, or inadequate? This is just to recap. So Edwin, I believe, will be providing a poll. Is that correct, Edwin?
Yes, I already have sent the poll. There's some colleagues who are sending in messages saying they cannot see the poll. So most gadgets, well, not most gadgets will show you a pop-up, and then you can just respond to the pop-up. Some gadgets, phones or laptops, might have blocked pop-up messages. So in that case, just go to the chat and scroll, and you'll see a poll embedded within the chat, and then you can select the answer from in there. Don't type the response in the chat, because then there I can't tally it.
So we'll go back here, as you can see, normal, conditional, abnormal, low velocity. What is it? A, B, C, or D? A, normal. B, conditional. C, abnormal. D, non-diagnostic. We'll give it a couple of more minutes.
This is a tricky one, so I think let's give a whole 5 minutes.
Yeah, fair enough.
Clement, you typed in the chat. Please go to the chat and look for the poll and select the option.
Have you voted, Edwin?
Myself? Oh, yes, I did. I did.
I'm sure you got it right this time as well.
I think I did. I think I did. I've been paying attention, so I should have gotten it right. Keep the results coming in. Can you switch back, Ibrahim, to the
Parameters?
the normal ranges, so at least we can have a comparison?
Yeah.
So that's the comparison on there. Less than 170 is normal. Well, it's considered normal, but there's just a risk of 2% for stroke. 170 to about 199 is a 7% chance of stroke, and that's conditional. And then over 200, there's a 10% chance of stroke, and that's termed as abnormal. If it's less than 70, then there's possible vessel occlusion, and then alternative imaging might be used, like MRI. Did I get it right?
Sorry, say that again?
Less than 70 there's possibility of vessel occlusion, and so you'd go for alternative imaging like MRI.
That's right. Yeah.
So yeah, I'm paying attention.
So what, is that your answer?
No. I'm just giving all the options.
Okay.
I went through all the options, yes.
Sure.
Let's go back to the case so that people can look at the case again. That's the case. It's a 5-year-old female with confirmed sickle cell anemia, and this was annual screening.
And we're interrogating the middle cerebral artery here.
This is the MCA.
And like I said, nothing's flipped around. You can clearly see.
There's no tricks in this one. There's no tricks in this one.
There's no tricks in this one. This is just, it's right on the screen.
Yeah. So let's give it 1 more minute, and then I'll tell you the results. The trick is attention to detail. That's the trick. That's the trick.
Attention to detail and the presentation.
Good. Yes, attention to detail and attention to the presentation as well. Okay, I'm now going to get you the results, yeah?
Sure, let's go.
So 60% think it's normal.
Okay.
38% think it's a conditional study. 2% think it's abnormal. None of the participants think it's non-diagnostic.
Okay, that's good.
There's a funny one in the chat. So Clement Clement says he has changed his mind. He thinks it's conditional. He thinks it's conditional. Clement, you've changed your mind. You think it's conditional.
So
All right.
Clement, from where to where we went?
He now thinks it's conditional. He had chosen normal at the beginning.
Normal.
Yeah. Now he thinks it's conditional.
Now he thinks it's conditional.
Yeah. All right.
Can we ask? Can we ask why Clement thinks it's conditional?
Let's find Clement. Let's find Clement. Clement, I'm going to unmute your microphone. I wish you can help us and tell us why you think it's conditional and not normal anymore. Clement, I have unmuted your microphone. You can unmute on your side and please tell us.
Okay. Are you able to get me?
Very loud and clear. Good.
All right. Yeah. So having looked at the peak systolic velocities, I think I'm seeing on the other side it's 194, and on the other side it's 180 something. So the baseline for the normal should be maximum of 170. So that's why I've changed to conditional risk.
So you went to conditional risk.
Yes, because it's above 170. So that's 194 on the other side and 180 something on the other side.
So 194 here and 186 here, right?
Yes.
Thank you, Clement. Ibrahim, I think we should pick someone else and see what they think as well.
Okay, sure. So Clement, and the funny thing is, Clement changed from normal to conditional. So he had an epiphany that's come to him.
Let me find someone else for you. Let me go to the chat and see. Okay, someone says please show the normal values again, the ranges.
Sure.
Post the normal ranges. I want someone who thinks otherwise from Clement, and then they post it in the chat, and then we'll get an opinion from them. If you don't think Clement is right, go into the chat and post the option that you think. This time around, not on the poll, in the chat. I want to pick you. Okay, let me pick someone called Nesta Odoy. Let me find you. I'm going to unmute your microphone, Nesta, and then you can tell us why you think it's normal. Go ahead, Nesta.
Yes, good afternoon, good morning to you all.
Good afternoon, good morning.
Yeah, me, I think it is normal because we are not using the peak systolic velocity, but we are using the mean. And on the right, it is saying 122. Then the left one is saying 118 centimeters per second. That's why I think it is normal, because the other normal is below 170 centimeters per second.
Thank you so much. We're going to
very
find
much,
out.
Nesta. Thank you very much, Nesta. So Clement changed from normal to conditional, and Nesta has from the beginning said it was normal. So let's find out what it is.
Wait. I want someone from the abnormal group. So we have about 2%.
You're right.
We have about 2% from the abnormal group.
We have a 2%. That's correct. Yes.
Yes. Let's see. I need someone who thinks it's abnormal. I want someone who thinks it's abnormal. If you think the waveform is abnormal, please post in the group and I'll unmute you so that you can give us your opinion. Anyone?
Okay, Edwin, I think we'll just
Yeah, just
the two
go ahead and
the 2% maybe it's become 0 right now. You know, so we'll move on. So Clement changed from normal to conditional, and like I said, Nesta has already said it's normal. So unfortunately, Clement should have stuck with his original choice, because it is in fact normal. Okay, the reason why, as Nesta has keenly seen in the mean TCD here, that's the time average mean velocity, as we said in the presentation before. We're not looking at the peak. We're not focused on the peak. And as you can see, that's the peak systolic velocity, and that's 194 on the right and 186 on the left. So Clement was initially right, but I think he maybe got a little bit more peer pressure from the 60% that said it was, from the 38% that said it was conditional. So, like I said, I have to emphasize enough. We are looking at the time average mean on here. That's the parameter we will always look for, because that is the parameter that was used in the STOP trial, and that was the parameter which provided a significant benefit for all the pediatric patients that have had annual screening. So always look into the mean and don't be fooled by the peak systolic velocity here. Okay, so because it falls below the 170 mark, it is normal. Good. So this was the case. The exam was considered normal. Under the trial, the STOP trials, it was below 170. This patient, TCD results placed her in the normal category described as STOP. Treatment and follow-up, patient with normal STOP criteria can be screened annually. So she was already screened annually, and that will continue to be the case for the next 11 years at least, as she is only 5 years old, until she gets to the age of 16, and then after which she will be moving on to the adult services. Next question, Edwin.
Yes, I'm going to
Let's
post
have
the
a
poll
look.
again.
Let's post another poll. So
Another poll.
again, we are looking at, in fact, Edwin, can we is it too late to put another poll here?
Do you want me to create another poll?
Yeah, let's
For the
not
same
only
case?
ask, I'd like to know which artery our viewers and participants think that we are interrogating, and after which, if it's normal, conditional, abnormal, or non-diagnostic.
Okay, so I've already launched the one asking whether it's normal, conditional, abnormal, or non-diagnostic. I can launch one after this.
Okay. Well, I mean, maybe just ask our participants to write on the comments to think
Okay.
what vessels that we are interrogating.
All right. So I've already posted the poll. It should have popped up on your phones or on your laptops. If you can't see it, go to the chat and scroll through the chat. You'll see a poll saying case 2, study the waveform. How would you categorize this TCD study? Do you think it's normal, conditional, abnormal, or non-diagnostic?
Again, there's no mischief going on here. This is just this image. There's nothing being flipped. There's nothing being disingenuous. It's just look at the image, look at the parameters, think about the parameters. We can go back to the parameters as well. Normal, conditional, abnormal, non-diagnostic. I think we'll give it another minute, and
Yeah.
then Edwin will enlighten us with your thoughts.
Yeah. Keep the responses coming in. So I see, Manuel, you put your response in the chat. I hope you did actually respond to the poll as well. So that I can pick up your the statistics on that. Celestine, good. Alex, good. Ian Kemboy, good. Shamsuddin, good. Roy Basimwa, good. I can see your responses coming in. Let's give it one more minute and I'll tell you, I'll hand over to, I'll tell you the poll results and hand over to Ibrahim to tell us if we are right or wrong. But I think I've been doing quite okay because I haven't gotten any of these wrong. I've been very attentive throughout your talk.
Yeah, I'll trust you, Edwin.
Isahaku, did you see the poll? Did you get the poll in your chart? If you did, oh, I see Isahaku says they can't see the poll. Where you're typing your messages, if you scroll a few messages up, you should land on the poll. It comes in as a message as well. Alex Chizito says they won't know if I get it wrong. These people don't trust me, Ibrahim.
Sorry, say that again.
Someone in the chat says they won't know if I get it wrong. I think you
Can
need
I
to
just
show
say,
that.
Edwin is a very trustworthy colleague. I've known him for many, many years, and
Yeah.
I'm pretty sure he got something wrong.
I got everything right. I got everything right. Okay, so should I tell you the results now?
Yeah, let's go.
Good. So 5% of the participants think it's normal. 69 think it's conditional. 20%, 21% think it's abnormal, and 5% think it's non-diagnostic.
So 5% normal, 69% conditional,
yeah,
21% abnormal,
yeah,
and D is non-diagnostic.
yes.
How much? Sorry, how many?
5%.
All right. So let's see if we can speak to anybody who thinks it's non-diagnostic. Is that appropriate?
Yeah, that's fine. Anyone who thinks it's non-diagnostic, please send a message in the chat and I'll pick you up and we can hear from your opinion. Would want to learn from you. And by the way, this is not to like make fun of anyone. It's a learning process. We want to see what your point of view is. You might convince the rest of us as well. So if you think it's a non-diagnostic, please send a message in the chat and I'll pick you up. I don't see anyone in the chat, Ibrahim.
No? Okay. How about
We look
all
for
right,
the
just
normal.
yeah, okay, normal. Yeah, go on.
Okay, anyone who thinks it's normal. Let's see if I have anyone in here saying normal. I can pick them up for you. Most of the people are insisting it's conditional.
Yeah. Okay. So should we just move on?
Wait, let's see. I have a new message here. What is it saying? Okay, no, you can move on. It's a question. I'll give it to you at the end of the presentation.
Sure. Okay. So I think so. 69% said it was conditional, and 21% said abnormal.
Yes.
Yeah. So in terms of the image here, the value that we would look for is time average max, 193 centimeters per second. It is within the conditional parameters, correct? It
Correct.
is within the time frame and it's below 200. So essentially, yes, it is conditional, but it's within a close parameter of abnormal. And you have to understand, you have to give a 10% leeway each way in how you do the scan because there's a lot of operator dependency. For me, yes, within conditional, and that is the actual correct answer. However, as a diagnostic personnel, I would also be wary that there are parameters and areas that will not be covered thoroughly. So when it's when the results, for example, is 191, 95, 98, at that point, I feel uncomfortable to just consider it as normal, as conditional. So, for example, if it was 180 or 179, is that the same conditional as 193? I wouldn't treat it as the same. I wouldn't treat it as the same. And depending how much of a high conditional it is. So, for example, if it's 179 and the parameter, so let's go back to parameters. So if it's around, actually, I would prefer to show you this parameter here. So if it's conditional below 200, but it's in the high conditional area when it's above 190 centimeters per second time average mean, then I would also be wary of how close it is to abnormal. And at that point, even though I would schedule a examination between 6 to 8 weeks, I would also mention that the close proximity to abnormal is a cause of concern. So in summary, it is conditional. However, it's something that you'd have to be wary of how high the conditional value it is and how close it is to abnormal. So I would usually almost tailor the follow-up to the patient considering how close it is to 200. Okay? Good.
Okay. So in that case, it means about 90% of the participants were correct.
Yes, yes,
Oh.
yes.
I have a quick follow-up question on this case. And that was posted in by Clement. And he's saying in such a case where you're hedging between conditional and abnormal, how long would you schedule the rescan?
All right, so let's go back here. As you can see here, I would do a rescan in 6 to 8 weeks. So usually when you have conditional, it's 3 months. When it's high conditional, anything above 185, I would do 6 to 8 weeks. Once it's abnormal, considered abnormal, I would do 1 week. And I haven't really discussed this much, but if it's high abnormal, anything above 220 centimeters per second, that's an urgent referral. That is an urgent referral. That's something that needs to be addressed on the day by a consultant hematologist or pediatric consultant that need to address it immediately and look at a tailored plan for that patient in time. It's no longer diagnostic. It's no longer beneficial to continue the diagnostic process. There could be an imminent risk of stroke at that point. So at this point, we would tailor it to the patient itself. But in the example that I said before, I would do a examination within 6 to 8 weeks, but I'll be wary. Sometimes I might even make it a little bit less, more towards the between 4 to 6 weeks at that point, considering if it's just below 200 at that point.
Thank you. You also wanted us to guess not guess, but you had wanted us to tell you what blood vessel it is.
Yeah, what vessel was it?
So going through the chart, most people think it's the MCA. I don't have the statistics for that, but I can see MCA. I have a few who think otherwise, but most of them think it's MCA. Nesta Odoi think it's ACA. And Isahako thinks it's ACA as well.
Yeah.
Shamsuddin thinks it's ACA. ENK Boy switched from ACA to something else, I think. But most of the people do think it's MCA.
Okay, good. And it is the MCA. As you can see here, the vessel, it's going towards the probe, and it's more superficial, as you can see here. And if we go by previous images, as you can see, the MCA M2 region, and as you go down, the circle, you're approaching the circle of Willis here, and anterior cerebral artery is in the more anterior aspect, and the posterior cerebral artery more in the posterior aspect. So that is correct. It's MCA.
And Clement asks, at what depth was this picked?
This image here?
Yep. Does it show on the image?
It doesn't actually show on the image. It's not something actually. I didn't take this image myself. This is just the kind of more of a image to see where our participants and colleagues are looking for in terms of velocities and the time average mean velocity. I don't have the depth on this image, unfortunately.
Okay.
And with this, I thank you all for listening. And I hope this was a insightful and worthwhile presentation. I hope any questions, please forward on to Edwin. And your feedback will be very much appreciated. As diagnostic personnel, we always are looking for feedback to understand how we can be, how we can get better at what we do, and then essentially grow and progress in our presentation style and way of relaying information onto fellow colleagues in the diagnostic world of ultrasound. So with that, I pass the floor to Edwin. Thank you very much for listening, and I hope this was a worthwhile experience for you guys.
Thank you, Ibrahim. I advise that you don't take off your presentation, because I have a feeling some of the questions being asked are going to need you to go back to the presentation.
Sure.
And so now I'm going to open the floor to questions. I already have some questions that were asked, so I'll just quickly go through them, and then you can answer one by one as we get more coming in. So Daniel asked, is there any importance? Is there any important to add carotid Doppler ultrasound for screening children with sickle cell disease? I don't know if I got that question correct.
Okay, so
He's
is there
asking
any
whether
importance?
in interrogating the carotid Doppler?
It's a very interesting question, actually, because I'm currently involved in research that will be looking into carotid Doppler, carotid arterial disease involving the internal carotid and middle cerebral, common carotid artery, and the relationship between risk of stroke. At this moment in time, we are following the STOPS trial for guidance for the diagnostic purposes of ultrasound and TCD. Diagnostic purpose of TCD and stroke. I think there will be a more developed field for carotid Doppler as well. There are some early trials and data says that there could be a direct correlation between carotid disease and instances of stroke. However, it's still an early preliminary findings, and there's nothing concrete just yet. But I feel like this is a developing field, and I guess the word is watch the space.
Thank you, Ibrahim. I have another question. It's actually a question that was running on my mind as well. So Shamsuddin Aliyu did ask, do you have to shave the patient's hair in preparation for the scan?
Shave the patient's hair?
Yes.
I've never had to do that in in many years of doing this. No. I mean, in most cases, you can get a transtemporal approach without, I guess there's independent variation between each patient depending where your hair is growing, but in most cases you don't have to, because the location is a temporal region, and there will be cases where hair is obstructing, but as long as you get a good contact with gel and surface, at that point, in most cases, if you obviously you don't have to press too hard, but in most cases you will still get a good Doppler, spectral Doppler waveform. I think in extreme cases where there's a lot of hair, that might be the case, but I've never had to experience that so far in thousands and thousands of scans that I've done.
Thank you. There you have it. I have a question from Daniel, and he's asking, can you use the waveform appearance to determine normal, abnormal, or conditional? Like on the image, there's closed window spectral broadening.
Yeah, so we're talking about the spectral broadening with regards to the spectral waveform.
I'm assuming so. I'm assuming that's what he meant.
Okay, I think it's always better to allow for the ultrasound machine to determine the velocity values. I think as humans, we are flawed in our analytical skills at times, and just looking at this image now and not having the time average peak velocities. If you just look at the peak systolic velocity, it might look high. I mean, it looks quite elevated, but you can't tell the time average mean here. That's not clearly visible. So you focus on the time average mean and allow the software and the machine that you're using to correctly estimate the time average mean. If it was a more of a peak systolic velocity, then you can look at it here and you can understand that the peak systolic velocity is above 180, as you can see here. So, but you can't distinguish what the time average velocity is. So it's something I would always allow for the correct settings and the correct parameters on the ultrasound machine to establish.
Thank you. How many readings should we take on one vessel, say the MCA? And that's a
Okay.
question from Ian Kemboy.
Yeah. So how many samples? It depends if you're using a non-imaging or imaging. So if we have a look, if I go back to non-imaging, for example, when you're looking through the vessel, you have to go in depth of, for example, you start on 42 millimeters, and the machine allows you to go every 2 millimeters throughout the vessel itself. So you can take as many as you want, but with non-imaging, you're forced to go through the whole vessel, and so you don't miss any elevated or high velocities. Whereas imaging, you actually, let me go back to imaging. Imaging, you see the vessel, and then you have to take samples. So with imaging, I usually take at least 3 to 4 samples. I would start with the most distal aspect, 1, towards the middle, 2, 3, and the one where you get the ACA involved as well, as you can see here, the ACA. So I would take between 3 and 4 measurements of the MCA, at least, because that's the vessel that is most appropriate to do that with. And then ACA, is generally 1 or 2. Same thing with the PCA and the ICA. So I would take between 3 and 4 measurements of the MCA just to make sure it is well interrogated, and I think it's good practice so we don't miss any high velocities.
All right. I guess the follow-up question to this would be, so what do you consider then? Do you use an average of all these measurements that you're taking? What if one of them is falling within conditional and one is falling within the abnormal? Which one do you take?
No, you used the highest average mean, the highest one.
So you go for worst case scenario.
Yeah, you have to use the highest one. You don't average the average already. So you have to take the highest average that's coming out with. So I would always, because the whole point is that we're looking for narrowing. So you don't offset areas of narrowing against areas that are not so much narrowed. So you always take the highest.
Thank you. I have an important question from Isahaku, and he's saying, the chart that you showed, the parameters, are they applicable to Africa? I guess his question is, was the research performed, and are the results transferable to African conditions? Are they generalizable to Africa?
Are we talking about the trial?
I'm assuming the chart that you showed for normal and abnormal was derived from the trial.
So that's the trial that was multi-centered trial that was across many different centers, and it's sickle cell disease is sickle cell disease.
Yeah.
And essentially, these parameters should be transferable to all areas of the world.
Generalizable.
Reason being, it's the manifestation of the disease is the same in Africa as it is in North America or South America. Is the mutation is the same. So in this respect, I would say it is quite transferable to Africa.
And I'm not saying this as an authority on this, but I would want to assume it's actually more generalizable to Africa than it is to any other part, because like the statistics showed, sickle cell disease is common in sub-Saharan Africa, which means whatever it is during the trial, the data must have been collected mostly from people of African descent. That's what I'm assuming.
Yes, absolutely. And like I said here as well, I encourage our participants and viewers to look through the trial data, and this is easily obtainable on, if you just search on Google, the stroke prevention trial in sickle cell anemia, the STOP trial, and essentially that will provide all the background and how they got the data and how the actual research was carried out. I think it's very insightful and highly recommended.
Thank you. There was a question from Enyasu Samuel, but I guess you did talk about this. I'll ask it again anyway. How can you use the waveform to differentiate between MCA, ACA, PCA, etc?
The waveform?
The waveform, yes. It was part of the quiz, actually.
Yeah. I'll just cover it quite briefly. So as you can see here, with the MCA, okay, let me get the one here. Look, so with the MCA, differentiating between different vessels, this is a non-imaging approach. You have to think about the depth in which you are in. So if it's for example 40 millimeters, you will know that's not the PCA. If it's not, at that depth, you will understand that the PCA would not be at that point. So once you have the MCA at a certain depth, now you know which area of the brain you are covering. So if you are in the MCA at say 42 millimeters, so at that point you know where you are, and then you use the MCA interrogator and go increase the depth at 2 millimeter intervals until you join a point where the flow is all going towards the probe and away from the probe. At that point, you will understand that you are in a bifurcating point between the MCA and the ACA, because the flow is going up towards the ACA and the flow is going towards the MCA. So at that point, you know the differentiation between the two vessels, and then you angle the interrogation window more anteriorly to get more of the ACA, which will look like this right here. And then if you angle it more posteriorly towards the PCA, we will look something like this. So it's not only the waveform that will give you your parameters and understanding of where you are in, it's also how you angle your probe, listening to the different waveform sound. Like I said, each waveform has its own distinct noise. And let's have a look at the imaging approach. You can see here, you will know the differentiation as basic physiology and anatomy. You will know which area is where exactly. That's it.
Thank you. Let me pick another question for you. So, for purposes of sickle cell anemia screening, which of the vessels is most important to assess? That's a question from Ms. Haku.
Yeah. So the STOP trials always put the most emphasis on the middle cerebral artery, terminal internal carotid artery, and they recently added I say recently, it was I think just over 5 years ago, they added the anterior cerebral artery as well. So these are the three vessels you will always have to focus on as the core fundamental intracranial vessels that will give you the intended results. So middle cerebral artery, internal carotid artery, terminal point, and the anterior cerebral artery. So that's what all the research was done on. The posterior cerebral artery, again, this is just good practice. It's not as, I don't like to say it's not as important, because all information is important, but it's not as relevant based on the studies.
Good. And I have another question from Thakar, who wants to know whether the parameters you gave us, the 170 cutoff,
Mhm.
applies to all vessels, MCA, AC, and PCA, or are there different cutoffs for different vessels?
No, it's all to all the vessels. That's the parameter that was used for all the interrogated intracranial vessels. So I would always just focus on that vessels, and based on those vessels, it will be the parameters used.
Let's see.
So one more question, one or two more questions.
Yeah, let's pick one. Let's pick maybe two more and then we're done, yeah?
Okay.
There's a question from Adia Kajimu. She says, do you utilize the Lindegard ratio to differentiate between vasospasm from hyperemia with TCD within the TCD study?
Sorry, I didn't quite hear that. Say that again, please.
Lindegard ratio.
Okay.
Do you utilize the Lindegard ratio to differentiate between
Vasospasm, yeah.
a vasospasm from a hyperemia?
Yeah. I have to say no, we don't. We primarily focus on the time average mean only in this respect. I think the Lindegard ratio is more usually in adults, I believe, if I'm not, I might be mistaken, but it's not something we would use in our diagnostic parameters here.
Good. Let's pick one more. There's one more. Paul was asking about antenatal obstetric screening and if you're able to pick this up in babies. Paul will discuss this when we come to fetal imaging and the use of Doppler in that. Look out for upcoming webinars. We'll discuss this. This was strictly for pediatric patients. And yep, I think that's pretty much it.
Brilliant.
Oh wait, kindly repeat the distance of MCA from the probe.
So we start with around 40 millimeters.
Okay. 4 centimeters, basically.
Yeah. Generally, you can go slightly lower, but that would you have to have a starting point. So a good starting point would be around 40 millimeters.
Okay. This question I'm sure you answered, but I'll ask you again anyway. It's Rindy Twist who is asking, which window do you use to interrogate the MCA?
Okay. Let's have a look. Again, the middle cerebral artery. You see, this person had some hair here, so a little bit of sideburns. You can still get it. So this is the transtemporal region. That's the most commonly used and most. I wouldn't say the most. It's always depending on the operator, but it's the most commonly used way of interrogating the intracranial vessels. Again, you can have the transorbital or suboccipital and the submandibular regions, but to be honest, I just primarily focus on the transtemporal region as my go-to for these examinations.
Thank you. Well, I guess we have to come to the end. I know there's a lot more questions. I will have to. We'll take these in our WhatsApp group. I saw someone asking about the WhatsApp group. There's a WhatsApp group where we share cases, and if you have any questions regarding today's presentation, please, one of our team members will be in touch with you from the chat to direct you on how to join our WhatsApp group. Look out for our upcoming webinars that will be announced soon. And also importantly, we'll be projecting or uploading these presentations on our social media platforms like YouTube, and importantly, follow the channel so that you're kept in the know. Join the WhatsApp group. Will be. I'm also, from my side, I would like to say thank you so much for sparing your time and sacrificing your personal time to be with us and learning from Ibrahim. I want to say a special thank you to Ibrahim. You've always been very helpful, and whenever we call on you to come and give us a talk, you never say no. I want to inform when we're still around that. Thank you so much, Ibrahim, and
thank you very much for having me.
Thank you so much. And please, within the WhatsApp groups, wait for our communication regarding the upcoming webinars, which are going to be as interesting or even more interesting than what we already have. Thank you so much. I now call the meeting to end.